Now we are going, while it's taking up the projection, we are going into the gray zone of pediatric cataract surgery. The subluxated lens is one of the dilemmas which I also face for a long duration. Uh, I also faced for a long duration while doing pediatric cataract surgery, and I initially hesitated in doing it because there are publications that in these children, when they are operated, the chances of retinal detachment is much higher. But there are children in whom you have to intervene. Children with counting finger vision, 660 vision, not improving with refraction, getting a very high myopia and very high astigmatism in their refractive error. So with some courage, I started doing subluxated lenses. And results almost 3 years now, and the results have been till date no retinal detachment. And so let's go through the journey in which there are various methods. Each time you will get a different method in these surgeries that are shown. So in this case, what you see, the lens is subluxated. We first use intracameral xylocaine. Then, chondroitin sulfate is very important because you don't want the vitreous to prolapse in the anterior chamber. The most difficult being anterior capsulorhexis because the half of the lens is behind the iris. So after initiating the initial rhexis, we used capsular hook to bring the lens towards the center. And then a CTR was placed, cortical aspiration was done. At this stage, we implanted the IOL, and what you will notice, the rhexis is very small. We have ended up with a very small rhexis. That too has to be taken care of because then capsular phimosis will occur, visual axis will get opacified. So with a scissor, we enlarge the rhexis, and we need to do it quite often in these children because invariably you will end up with a smaller rhexis. The vitreous was cleared from the weak zonule area, and then a Cionni segment was used for scleral fixation. And again, as Dr. Sudarshan Kokar was telling, that these are slightly older children, maybe between 8 and 9 years or 10 to 12 years. We don't do it in a very small child in these kind of surgeries. And after Cionni segment fixation, the side ports were hydrated and got a good result. Now, this I will skip because small rhexis management I have already shown in the previous video. When at some stage when you are gaining confidence, things will go wrong. And in this case, if you see, while taking the second railroad technique suture, there was a sudden jerk, and I ended up rupturing the equatorial capsular bag, and the whole, with the CTR in place, the Cionni segment in place, the IOL in place. So you are in a very difficult situation now. I didn't know how to handle, and then we started trying fixation. And while fixing, when we were pulling it, it's the Cionni segment is coming to the center of the visual axis. Not the ideal situation. Damage has already been done. How do you salvage it? Removing everything from the bag, I didn't think it was a good idea because that would become much more destructive than this. So we decided to fix it in whatever we can do, and what you can see with the anterior capsulorhexis margin, the Cionni segment is sticking on, and till I saw this is almost 1 year old video, I saw this child just last week, he is still maintaining good 6/9 vision. Then that was the last case which I did with Cionni segment. So then after that, I tried doing Cionni Ring because initially why I was not doing Cionni Ring, because Cionni Ring manipulation, the rotation of Cionni Ring in the bag will cause more stress in the zonular fibers. But after having burnt my fingers, I did Cionni Ring in the next case. which was taken up. And if you notice, Cionni ring is being implanted before cortical aspiration. And the first case went on very smoothly. The surgical time went down drastically because there was just one implant you are giving in the eye and the IOL. And the one important thing about Cionni ring is it comes as a right-sided and left-sided. So two-sided Cionni ring comes. So after the ring was inserted, cortical aspiration was done, and it was fixed to the equator. So this is one of the ways of doing it. The last video now what we are coming to is, again, when in this case what happened, when after the rexes, I tried a different technique in this case. After initiating the rexes, we did cortical aspiration and then try to insert the Cionni ring and see what happens when we are inserting the Cionni ring in this case. The ring goes well, and you can see it's going on well in the bag and progressing smoothly. But once the whole ring is there, here it starts coming out from the bag, and slowly it progresses this side and the whole ring is out of the bag. Now you have a large implant about 12-13 millimeter diameter, and which is out of the bag, which we have to reinsert in the bag. Different maneuvers over a period of 15 minutes was done, and then finally a reverse dialing was tried, in which we could successfully implant the Cionni ring in the bag. So these are the tricky situations in which you can land when you are trying such surgeries, which we have to be well prepared for. And then the lens was implanted and went on smoothly. Thank you so much.